And if you can imagine being in any profession where 40% of the problems that land on your desk, you don't know what to do about it, it's going to burn you out after a while. But people who learn how to do this, these patients that formerly would make a doctor beat their head against the wall, now they become a source of great personal reward in your profession.
Hello and welcome to Disruptors at Work, an integrated care podcast. We are excited to discuss the groundbreaking science of chronic pain and other symptoms with one of the world's leading experts. I'm Dr. Cara English, CEO of Cummings Graduate Institute for Behavioral Health Studies, special host for today's episode. And I'm joined by Dr. David Clarke, the president and co-founder of the Association for the Treatment of Neuroplastic Symptoms. Dr. Clarke has an extensive background and expertise in diagnosing and treating neuroplastic pain and illness, which sets the stage for our conversation. Let's get started. Hello, Dr. Clarke, and welcome.
Great to be back with you, Cara. Thank you so much.
It's wonderful to see you. I was just reflecting on as I was preparing for our episode today, reflecting on the class that I took from you that started all of this many years ago, over 10 years ago. So we've known each other for a little bit of time now.
Yeah, and you were absolutely one of the best students in that class. I still quote your essay on one of the cases that I used in teaching new students.
Well, it's funny that you say that because I often use that same case as an example of just why we need integrated care so badly.
Yeah, that one, it was chosen deliberately to be exceedingly complex, but there are millions of people that have this condition where just a few simple questions can unlock what's going on and save people untold years of grief and suffering.
Yeah, I absolutely learned that in your class, and we ended up, when we started Cummings Graduate Institute, offering your class under the title "Solving Medical Mysteries" for that exact reason, because so often these kinds of complex cases go under the mystery heading in medicine.
We doctors are all trained to look for. We're trained to look for organ diseases and structural damage, and when we don't find it in somebody who's got pain or illness, unless you know what to do next, you kind of throw up your hands as a physician and say, I can't find anything wrong with you and I don't know what to do for you. And the typical teaching about people with this condition is that they're neurotic, they can't handle their own stress, you can't diagnose them. The best outcome is they're going to have to live with it. It's not really part of a doctor's job description to deal with this. And those are all myths. Every single one of them is false.
And I really liked getting to know you a little bit better because your ultimate profession is gastroenterology, right?
That's right.
So how can you share with the listeners? I love the story of how you came to this field as the solver of medical mysteries for so many patients and their clinicians and clinical teams as well. Can you share that a little bit?
Yeah, it's actually a little embarrassing to admit as a physician how I got to my 8th year of formal training, thinking that I knew what I was doing, only to encounter a patient I didn't know the first thing about diagnosing or treating. She was sent to us at UCLA from another university. She had, severe symptom. She was averaging 1 bowel movement per month for 2 years. And the other university found no reason for this. We did some specialized testing and found nothing. I was doing her exit interview and basically telling her, you're going to have to live with this, but asked a few more questions and stumbled on the fact that she'd been severely abused as a girl. I had never heard that from a patient before, had no education that I should be looking for such a thing, no idea that it could possibly impact someone's physical health 25 years later, as it did in this case. But fortunately, there was a psychiatrist named Harriet Kaplan who was certified in medicine as well. And I sent her to see Harriet thinking, maybe the patient can learn to live with this condition a little more successfully. But 3 months later, I ran into Harriet in the elevator ride that changed my career. And between the ground floor and the 5th floor, she told me that she had cured this patient with, 10 counseling sessions, just
Remarkable.
talking to her. She alleviated this incredibly bad health issue. And I'd never heard that was possible. So that was, just my ignorance was just compounded in so many ways around this condition when I started. Another area where I was wrong is I thought, I might only see 1 or 2 patients a year with this. So I prevailed on Harriet to teach me her framework over the last year and a half of my training.
Wow.
And I also thought, when I got into practice in Portland, Oregon, whenever I encountered one of these patients, I just send them to whoever the Harriet Kaplan was in my community. Well, I was wrong there too. There weren't any Harriet Kaplans. Everybody got cognitive behavioral therapy, which doesn't work very well for this. So they would come back mostly and they would say, I'm still having my symptoms. What do I do? And it was 5 or 6 patients every week.
Wow.
So it ended up, I've treated over 7,000 people with this because nobody else was doing it. And my patients were my teachers. There weren't any training programs. There weren't any books back in those days. No videos, no webinar courses, no international conferences, all of which we have today. But the patients taught me, and it was, a tough 5-year learning curve. But, not coincidentally, at the end of that, I worked for this big HMO at the time, and they voted me their Doctor of the Year. So they were clearly recognizing that I was onto something.
You were voted Doctor of the Year without having to invest thousands of dollars in that vote. That's an amazing thing in today's world, isn't it?
Yeah, no, that came as a big surprise. I had been gradually getting better and better at doing this work. I was solving these medical mysteries, people who had real pain or illness, sometimes for years, sometimes for decades. And I was alleviating their symptoms through the treatment that using the framework that Dr. Kaplan had taught me and my own learning from many, many patients. When you're doing something 5 or 6 times a week, you can't help but get better at it.
That's true, and yet we see so many physicians and nurse practitioners, midwives, etc., who really struggle with the humility that it takes to identify that you have something missing in your training, and the motivation to not just identify that there's something missing, but to really pursue it with everything you have so that you can treat those elements of what you're seeing in practice so often. And I think many more people often do go the route of, well, I'll just refer out because practices are getting busier and busier. I'm not trying to, blame the clinician by any means, but I think our system sort of sets us up for a little less than getting better at what we do.
Yeah. And it is a different way of thinking. I mean, the organs and structures and physiology are one way of thinking. And then this is obviously more psychological, and you have to kind of jump onto a whole new set of railroad tracks. When I'm teaching medical professionals, I'm talking about, if we're all plumbers to start with, we have to learn to be electricians to a certain extent in helping these patients. But I've taught many, many physicians how to do this. They absolutely love it. It transforms their practice. This is 40% of people that come into a primary care office. And if you can imagine being in any profession where 40% of the problems that land on your desk, you don't know what to do about it, it's going to burn you out after a while. But people who learn how to do this, these patients that formerly would make a doctor beat their head against the wall, now they become a source of great personal reward in your profession. I had one doctor who learned from the course on symptomatic.me. She took me aside at a conference and said these concepts had put the joy back into her work.
And that's what it's all
wonderful.
about. That has to be so fulfilling for you because, as a physician and as a clinician, I know burnout, how real and how quick it is to experience burnout and to be at that level of burnout and then have to recover. So few of us are able to recover when we're at that point. So it must be such a huge reward to you to hear that.
Yeah, and the following year, she said that she and her little group who had taken the course, the symptomatic.me professional training course, they had taught 70 other doctors in their medium-sized East Coast city how to do this. And
amazing.
I just wish that the rest of the country would catch up with that.
And the rest of the world.
Absolutely.
Give it time. You're working your way in that direction.
Yeah, once people see this, they can't unsee it.
That's
And
true. That's
it's,
true. That's absolutely right. And I think, back to what Maya Angelou and many others have said, know better, do better, right? So we can't unsee it. And so if we can do better, we should be.
yeah, and it's 50 million people in the United States alone who
Hmm.
are not getting the level of care they deserve. People with exactly the same symptoms from an organ disease or structural damage get good care from the U.S.
Absolutely.
healthcare system and most healthcare systems. But if they have symptoms from a brain-generated or neuroplastic cause,
Hmm.
um, typically they can struggle for years to try to find the right answers.
Yeah. I was looking at your website, and there's a statement on there that really hit home for me as a clinician myself, and also as a person who has had chronic pain, to cope with over time. And the statement is just, it's simple, but it's also so foundational to medicine. And at the same time, we're not seeing it being included in all medical training programs. And that statement is that chronic pain or illness not explained by disease or injury, or for which treatment is not working as expected, are usually caused by learned neural pathways in the brain. And these are called neuroplastic symptoms. So that's really what we're talking about when we say those words, which are a little complex. But I thought maybe you could unpack that a little bit more for listeners who may not have had the training that I've had with you.
Yeah, it's the neuroplastic term is actually quite simple. Neuro obviously refers to the brain and nervous system, and there are functional magnetic resonance imaging studies of the brain in people with these conditions that show that there's real anatomic changes. So this is a condition that is not all in your head. It is actually structurally in your brain. There's a real physiologic cause for this, and the symptoms are every bit as real as those from any other cause. But the plastic part in medical
Mm-hmm.
jargon means a capacity for change. And that's very hopeful. Yeah, and yes,
Mm-hmm.
the brain and nervous system have changed in a direction we wouldn't want, and that's what's causing the symptoms, but it can be changed back. And we have seen that now. There's a study from way back in '03 that showed an irritable bowel patient whose brain physically changed in response to treatment. And the Boulder back pain study scanned all their subjects, and the ones who got the new pain recovery psychotherapy, their brains physically changed in response to that treatment.
And it's incredible in my own practice how I've seen physiological conditions, anything from migraines to pelvic pain change drastically in response to the change to a better partner, a better relationship, a high quality relationship with a good partner. And that's definitely something that you talk about in your training with us, just the idea that the relationship quality directly relates to the experience and the manifestation of that physiological pain.
Yeah, I've had many patients where the cause of their physical symptoms, the cause of the shift in the brain was that they were in a toxic relationship, or
Mm-hmm.
there was somebody who mistreated them as a child who was still in their life as an adult. So
Yeah.
there's a lot to unpack there. Many of my patients grew up with what we call adverse childhood experiences, which
Mm-hmm.
can be anything that you would never want for a child of your own. And I
Mm-hmm.
ask my patients to think of it in those terms. Many of them will say, "Oh, it wasn't that bad," but when they think about their own kid going through the
Mm-hmm.
same things that they did, they have a much better idea of the magnitude of stress that they suffered. And one of the long-term impacts, and there are many that are stressful, but one of them is on your self-esteem and how you think about yourself as a person. Another one is your inclination toward focusing on the needs of others in your
Mm-hmm.
life so much that you don't put yourself on the list of people you take
Mm-hmm.
care of. And another one is being in an unbalanced relationship. If you grow
Mm-hmm.
up constantly as a kid trying to fix the problems in your household, it's quite common to find yourself in close personal relationships with people who have issues or problems or need support. And you end up very unbalanced in your close personal relationships, which is stressful, which can change the structure of your brain and lead to these symptoms. So, for a
Yes.
lot of my patients, we have to go all the way back and say, you know what? You were a courageous little kid who had to deal with a lot more than you used to think. And you deserve a tremendous amount of credit for the heroic perseverance that you showed coming through all of that. And if you can internalize that recognition of your own quality, then the relationships that you're in are going to change. You're not going to put up with unbalanced relationships. You're going to set boundaries around toxic people in your life. And that is going to change the structure in your brain, and your symptoms are going to go down. I've seen it countless times.
And it's not easy to do, but I think, what's special about you and what's special about many of the people who pursue the training with you is that they want to be the safe person to provide, potentially that first open door through medicine, the entry point to healing and the hope that you mentioned in just being able to know this can change. I can recover from this. It's going to look maybe a little bit different. The way that we pursue it might not be in a pill or in a surgical procedure, but this can change. And I think that, to be a person who is safe like that, you have to have done a lot of the work yourself.
Yeah, it's something that I had to learn, but even as a bumbling beginner back in the
Mhm.
80s, these ideas are so powerful that people were getting better. I'm sure if there was a video of me doing this work back then and somebody forced me to watch it today,
Mhm.
it would be really agonizing to see all the mistakes I was making. But even then, people were still responding to this and getting
Mhm.
better. And the patient that I knew um, was telling me that I was truly onto something is the one
Mhm.
that I put in the first story of my first book, which is called "They Can't Find Anything Wrong." And the
Mhm.
reason that the book has that title is this patient, basically said that she'd been hospitalized at a major university medical center 60 times for
Mhm.
attacks of severe dizziness and vomiting with no
Mhm.
diagnosis. She saw a dozen specialists. They got so frustrated, they had a psychiatrist come and see her,
Yeah.
and he pronounced her mentally healthy and sent her back to the medical clinicians. And she wound up in my hospital with one of her attacks and,
Mhm.
almost tried to kick me out of the room. She said, go off and see your other patients. You can't possibly do anything for me because of, 15 years of hospital admissions. But less than an hour later, we had the diagnosis and she was basically cured on the spot. And it was all
Unbelievable.
connected to her attacks were all connected to interactions with her abusive mother.
Yeah.
And once she saw that, I still remember her looking up at the ceiling and going, "Oh my God, I can't believe it."
Gosh.
And
The
I can't
connection
cure
moment.
everybody on the spot like that. I wish I could, but
Yeah.
it was so dramatic. I went
Mhm.
home and told my wife, I think I'm onto something here because this was
Mhm.
early in my career and I was still trying to figure it out. But when I cured that patient, I thought, I really have to make this a focus of my career.
Well, you've gifted us so many of us with what you've learned, which, is, like I mentioned, still to this day, something that I rely on. One of the things that always stands out to me when I think about your class is connecting the chronology, thinking about what is the trigger and when did it happen? And, that aha moment that you just mentioned, that making the connection moment, I've seen that in folks too, both friends and also patients that I've worked with. And it really is remarkable how they didn't make the connection before we had that conversation and we were really talking about what happened and when, and then we connect the dots.
Yeah, it's reminds me of a story that was told to me by a colleague actually from Tucson, not
Mm,
too far from you guys. And this woman had been running from doctor to doctor for unexplained symptoms for 6 months. And he was the one who found out that right before she became ill, she had been a hostage during the robbery of a store.
oh,
And
yeah.
for 40 minutes during that ordeal, somebody had a handgun pointed at her neck.
Hmm.
And she never thought to mention it to anybody. Nobody thought to ask, have you been through a trauma
Hmm.
right before you became ill, for example?
Hmm.
And she had other symptoms of post-traumatic stress as well. So the diagnosis was very clear.
Yeah, yeah. And again, I think that's something, the line of questioning that a physician uses, that any clinician uses, is important, and it reflects what we know about disease and injury and illness. But it also is so critical that the person feels safe enough to share, because people aren't going to share stories about childhood sexual abuse or rape, or these kinds, having been held up at gunpoint types, those types of stories in a 5 minute Q&A about a gastroenterological kind of symptom, for the most part. So it really gets to the joy of the physician, the person who came to the medical school, the medical program, to be trained to begin with to help people, rather than to have an appointment every 5 to 15 minutes. So I think that's really important too.
Yeah, my nursing staff who set up my appointments, they could tell from the nature of the referral which patients were going to have this. It was
Ah.
about a third of my patients, and they would
Mm-hmm.
try really hard to schedule those patients right before lunch or right at the end of the
Mm-hmm.
day so that I would have more time to talk to them. But I would take a very matter of fact approach to this, that all these highly personal questions, that they were just a
Right.
routine part of my
Mm-hmm.
evaluation. I'd be asking about substance abuse habits. I'd be
Mm-hmm.
asking about previous illnesses. I'd be asking about surgery, and I'd be asking about childhood stress. And I'd just try to
Mm-hmm.
fold it all into a matter of fact type of history. And it wasn't unusual for me to be the first or second person who had ever heard
Yeah.
some of these stories from the past.
Yeah. And I think that really speaks to the importance of your team understanding a trauma informed approach as well, because, if they're doing the scheduling, knowledge of what a patient, might look like, what the profile of symptoms might look like, and, finding a slot for them where there's, perhaps more time or a little bit of cushion, is so important. So I wanted to ask you a little bit about some of the symptoms. You mentioned nausea and vomiting. You mentioned, and we've talked a little bit about pain. But I also noticed that you're now beginning to talk about long COVID. I listened to one of your podcast episodes and you talk about that. And one of the others is Ehlers-Danlos syndrome, which has been popping up like mushrooms after a rain. It's everywhere now. In fact, two of the very close family members in my life have now been diagnosed with EDS. And so I wanted to know if you can talk a little bit about EDS, because I think a lot of people are learning about it on the internet. So I'm wondering if you can just, share some of the symptoms and how it might be tied to, some of the neuroplasticity that we don't want to attach ourselves to as, I have this lifelong thing now.
Yes, it's part of the history of this condition that
Hmm.
medical clinicians have long tried to make neuroplastic symptoms fit into a medical box and blame it on a biological condition of one sort
Hmm.
or another. And through the history of this condition, it's been blamed on a whole succession of different things. Peptic ulcer was largely blamed on stress,
Yeah.
back pain. Um, Ehlers-Danlos is the latest one. Chronic Lyme is another one.
Yes.
Multiple chemical sensitivities, electromagnetic sensitivities,
Hmm.
uh, chronic Lyme, if I didn't mention that, all kinds of different conditions that clinicians have tried to make neuroplastic symptoms fit into those boxes. And
Hmm.
Ehlers-Danlos is a genetic inherited condition of connective tissue.
Hmm.
It's not all that common, but it certainly does exist. And the range of symptoms that have been blamed on it
Hmm.
is just expanding beyond
Yep.
all reason.
Hmm.
The people who are advocating that Ehlers-Danlos is responsible for this huge range of symptoms will struggle to explain exactly how something that's wrong with your collagen in your body is
Hmm.
creating all of these symptoms. They
Hmm.
will struggle to explain why one person with Ehlers-Danlos has none of those symptoms and somebody else does have, sometimes lots of different symptoms. What's the
Yeah.
mechanism that leads from one to the other? And then when you ask them, have you done an assessment to see if the patient has any of the psychosocial stresses that are common in people with neuroplastic symptoms? Typically, they don't know how to do that.
Right.
They don't know how to look into childhood stress or traumas
Mm-mm.
or challenging personal relationship issues. They've never assessed their patients for that. So what they end up with is they've got somebody who's maybe got a mild case of Ehlers-Danlos, and they've got all these unexplained symptoms.
Yep.
And their reasoning is, well, we've got no other explanation for all
Yep.
these symptoms that you have. Therefore, they must be coming somehow from your Ehlers-Danlos
Mm-hmm.
or from any of a number of other biomedical conditions.
Yes, I
So
see that a
it's
lot.
basically the wrong diagnosis.
Yeah, I'm seeing that a lot too. I think, unfortunately, in an era when we already don't know a whole lot about women's health and wellness, and then we're, seeing a lot of cuts, in funding for women's health and research on feminine and female issues. It makes me really nervous because what that leads to, of course, is women seeking information from other women. So we're connecting on social media, we're talking with one another, we're maybe sharing some symptoms, but in the perinatal psychology world and in perinatal mental health, we always talk about how there are some symptoms that we just don't want to talk about in a group because they're contagious. And that can also be true. I've seen that also be true with pain, and with some symptoms that are often considered hormonal or part of a hormonal makeup that no one can really do through a lab or a true biometric way of measurement. And so it really begs for more research, but unfortunately I don't think we're going to see that in any time, maybe in the next
Yeah,
4 years.
pelvic pain is a big one as well, and
Hmm.
another condition called persistent genital arousal disorder, which is
Yes.
surprisingly to me is present in 2% of the population. I had no idea it was that common until recently.
Hmm.
And the uh, the pelvic pain, there was a specialty clinic in North Carolina that published a study that found that something like half of the patients that came to that pelvic pain clinic had a history of adverse childhood experiences. So it
Yeah.
was well over the number in the general population had
Right.
multiple adverse childhood experiences. The success rate of surgery for chronic pelvic pain, even when there are abnormalities in the pelvis, the success
Hmm.
rate is less than 50%. And
Hmm.
again, the reason is that they're operating and focusing their therapeutic attention on the wrong thing.
Yes.
These patients typically do not get an assessment for psychosocial stresses and neuroplastic symptoms from their gynecologic surgeons.
Right.
Um,
Right.
and
Who aren't trained and
and
don't have the information, don't know
that's right.
better, can't do better.
There was a gynecologist in my community. I never met him in person. It was all electronic, but he
Mm.
sent me at least one patient a month whom he had scheduled for a laparoscopy, which is you put a lighted tube into the pelvis and have a look around.
Hmm.
It's an invasive procedure, obviously.
Hmm.
He would schedule the women for that, but he would send them over to me first and schedule their laparoscopy for a week or two after they had their visit with me, because they would already have had all the tests up to but not including the laparoscopy, and he would want me to do a stress evaluation and see if I found anything. And he
Hmm.
had really good instincts for which people had these problems with
Okay.
neuroplastic pelvic pain. I don't think
Hmm.
a single one of those ever needed a laparoscopy because
So you
I
saved them from an invasive procedure.
exactly, yeah.
And I know that hopefully they knew what they didn't have to have and were grateful for it, but being able to
Oh
save
yeah, they
someone
did. I
from
mean,
an
the light
unnecessary
bulb
procedure.
moments. Yeah, the light bulb moments that people have when they see the magnitude. That key question. how would you feel if you were a butterfly on the wall of your childhood home, watching your own kid try to cope with everything you did, and just people, their facial expressions change, and
Yep.
they get a real sense of the issues being much bigger than they used to think. That's one of the
Yeah.
12 questions in our screening quiz that we have on
Mm-hmm.
symptomatic.me for people who are
Mm-hmm.
watching this and are wondering if their own physical symptoms could be connected to these issues. That quiz takes less than 3 minutes, and you can get a pretty good sense of whether any of this applies to you personally.
Yeah, and I think it's such a smart. I love the quiz itself because not only can people take it themselves to get a first initial idea on the website, but it really gives them some good information to take to follow up with a trained clinician. So I really appreciate that about it. Have used the hidden stress test that you provided us in the course many times in practice, and it's always been very valuable to have, even just to facilitate that discussion with a patient for the first time, like you said, the light bulb, the aha moment, to even create that level of insight is often the first step, that entry point
Yeah,
into
each of those
healing and
questions
hope.
comes with a line or two of explanation to help people
Mm-hmm.
understand, why we're asking that question and
Yeah.
what a yes answer means. And the more questions to which you answer yes, the more likely it is that you've got a neuroplastic cause for your condition. And
Mm-hmm.
you mentioned the podcast. It's called The Story Behind the Symptoms, where I interview patients who have been through this, some of them for a
Mm-hmm.
long time, and
Yeah.
talk about the whole range of underlying psychosocial issues that can be responsible. And
Yeah.
I've been very happy with how those have turned out. I think we're
They're
releasing
fantastic.
podcast number 4 this week.
Mm-hmm. Mm-hmm. They're fantastic episodes because I think for so many clinicians, but especially for the just anybody and anybody who's wondering about this, it can be so helpful to hear through another's experience. Sort of what was going on and how they made the connection, and also the successes that they've had. Because so oftentimes we hear in the news or online all of the symptoms, all of the struggle, but no successes. So I think that's really important. So if somebody were to listen in and feel like they could relate to some of the stories, or to visit the website and take the quiz, what would you recommend that they do if they think they might also be experiencing neuroplastic symptoms,
Yeah,
especially if
we've
they're having a hard time finding someone to listen?
Yeah, on the public page, we've got what we call a treatment program, and people who support us by becoming members.
Mm-hmm.
We definitely need that so we can reach more people who have this condition.
Yeah,
They can get a self-treatment program right there on the website, but we
that's
also
fantastic.
reference, all kinds of scientific, evidence-based self-help books, videos, video courses, a recorded conference. We're having another live conference in Boulder, Colorado, September 28th to the 30th in 2025. That last year we had 270 people from 8 countries that came, so
Wow.
that's another resource. There's a practitioner directory, well over 100 people around the country, and in some cases internationally, who are who have taken extra training to be skilled at helping people with these conditions. And a lot of them will, even if they're not local to you, they are willing to treat via telehealth, so they can
Yeah.
provide services in multiple states and around the world.
That's wonderful because I know, I still get requests, from folks who are looking for somebody in Arizona or, in the US. And so often there really isn't someone that I know of. So it's great to know that your website can direct people to resources that even if there isn't someone local, they could potentially interact through telehealth. That's wonderful.
Yeah, that's expanding all the time. I mean, we're
Hmm.
getting several new people that have taken the necessary training that we're adding to that directory every month.
That's fantastic. Well, I know your website is www.symptomatic.me. Is that right?
That's right.
Okay. And your podcast, The Story Behind the Symptoms. And then you also mentioned on your YouTube channel, you also have some videos there that folks can look at, and the 7-minute video called Pain Science Paradigm Shift, which was produced by a feature film director.
That's right. Yeah, she came to us. She had been debilitated severely by what was called long COVID at the time,
Yeah.
but it actually was a neuroplastic condition. She found our resources. She made a full recovery. She's got her
Wow.
life back. And she came to us and said, I'd like to do something with you guys. And so
That's
last year's
fantastic.
conference, she came and set up a film studio, with
Hmm.
all kinds of professional people running around. And
Yeah.
she filmed 110 people and
Wow.
got all kinds of incredible information that we're still rolling out. But
That's
her
wonderful.
biggest single contribution was this 7-minute video where she took the clinicians, the researchers, the patients
Mhm.
who had life-changing benefits and
Yeah.
wove them all together into 7 minutes. It's incredible. Everybody should watch that.
I totally agree. So we'll put a link to that in our show notes for sure so that we can direct more people to you and to your website and to opportunities to learn more. So on that note, I want to say a big thank you to you, Dr. Clarke. We are so grateful to have had you in our CGI community for so long now. You've made such a positive impact on our students and the way that we train our students to ensure that, you've handed the torch off to one of our students that you trained yourself, who is now, continuing on in your footsteps. And we're just so grateful for all that you've done for so many clinicians to help us learn what you learned, and to go from that point of not knowing to a point of knowing better to do better. So
Thank you,
thank you.
Cara. Yeah, your students are in the vanguard of this change. It is, literally going to change medical history. The first written description of these symptoms was found in an Egyptian papyrus from almost 4,000 years ago. And the treatment of this condition has essentially been one of one placebo after another
Yep.
for almost 4 millennia. And we are finally, in this century, going to see that change. And your students, your graduates, are among those that are going to be leading that change.
Well, we're lucky to follow in your footsteps, having learned from you. So we're very, very grateful. Thanks so much for your time today. And we'll definitely direct more people your way so that they can keep learning from you.
Thank you.
Thank you. If you enjoyed this episode, don't forget to subscribe and share. Let's keep disrupting healthcare together. Until next time.